We toured the new hall today, and it's going to be such a magnificent treat for this whole community when you walk in and you see this huge hall that will seat 299 people with a huge stage and perfect acoustics. So it's a real blessing to the community. And this foundation has raised half of the cost of that hall. And Jerry Capel, our CEO, has had a tremendous amount to do with that. So please give him a round of applause. And so also has our program director, Kunga, who is back with us now because she's had her son. So let's thank Kunga. All right, so I'm welcoming you to Medicine in Our Backyard, a series presented by the Newport Beach Public Library Foundation in conjunction with UC Irvine Health. And tonight we have three very special guests with us because Mike and Polly Smith have been with this program since its very beginning. They were at the very first meeting when it was thought up. They have sustained us with their financial support and with the constant interest that they've had in choosing our speakers and participating. So Mike and Polly and David, would you please stand up? And the basic idea was, wouldn't it be wonderful to bring into our library community, our library home, the fantastic resources that we have through UCI Health and with all of these phenomenal people. And it's been a program that we have had with us for more than a decade, so we're delighted that you're here. Now, how many of you are members of our foundation? Well, I see some of you aren't, and I want to urge you to become a member, to become a part of our community. And at this time of year, we have a little special reason to give you incentive. In June, we have a summer solstice celebration to celebrate new members. And if you join between now and June 15th, you will be invited to the summer solstice. It's a wonderful reception with wine and hors d'oeuvres, and you have a chance to meet your fellow foundation members as well as the board, library trustees, city officials. And so I urge you, if you're not a member of our community, to become one, because that's where we get our main support. We are a membership-supported organization. So now some housekeeping things. If you haven't silenced your phone, please do that now. I just did before I came up here. Also, we will have Q&A at the end. And so please, if you would hold your questions to the end. And we are videotaping this, and it will be available on our website and on our YouTube channel. So when you ask your questions, please don't be symptom specific to yourself. Try to make it a generic question so that it'll be appropriate for the video. And Dr. Sehgal will be up here afterwards if you have personal things that you want to talk to her about. So let me now introduce you to Dr. Sonia Sehgal. She is a board-certified UCI Health internist who specializes in the care and treatment of older adults. Her clinical interests include healthy aging, hypertension, osteoporosis, preventive medicine, and elder abuse. She earned her medical degree at St. George University School of Medicine, Granada. She completed an internship and residence in internal medicine at Maricopa County Medical Center in Phoenix, Arizona, followed by a fellowship in geriatric medicine at UCI Medical Center. In fall of 2021, Dr. Sehgal was named one of 12 Dean Scholars, a select group of UCI School of Medicine faculty members charged with implementing initiatives that advance training and assessment of medical students' clinical skills and develop the next generation of medical education scholars and national leaders, such as we're taking advantage of tonight. She is also leading the medical school's expansion of its geriatric and gerontology program and its workforce development efforts. Now, she's going to be talking to us tonight about preventing cognitive decline. If any of you have ever walked into a room and wondered what you came in there to get, you're at the right place tonight. So please join me in welcoming Dr. Sehgal.
Good evening, everybody. How are you? Great. I love it. You guys are a responsive audience. I love that. Let's keep the dialogue going throughout this next hour. Okay. It's my pleasure to be here today. I feel like it's a huge honor for me to come and speak. I grew up locally, probably about 4 miles from here. So it's always wonderful to see and be in the community and be with those who I grew up with and who I share so many interests with. We're going to start off the evening with a quiz because this is about memory, right? And we got to test ourselves. What's a geriatrician? What is a geriatrician? Who are geriatricians? I heard like older people. We treat the elderly. Absolutely. I find that when I go out into the community, a lot of times people don't know what I do and what my specialty of medicine is. And I'm so passionate about it that I want to make sure that you all know who we are and what we do. So geriatricians, we are either internal medicine, we're either internists by background or family medicine doctors. I happen to be an internist, but half my colleagues are in family medicine. And after we complete that training, we do an additional year or 2 focused on aging and the aging body. And we differ from gerontologists because gerontologists study aging, and they have advanced degrees as well, and they're doctors of gerontology and they're PhDs, and we're the clinical folks, so we work side by side. Now you might wonder, well, and a lot of people tell me this, like, I had clinic this afternoon and my 96-year-old patient said, well, yes, I'm aging, but I'm not old. And I like to hear that, right? So what does it mean? Like what age do geriatricians actually start seeing patients? We actually go as low as 50, right? So, and part of this talk, I'd like to emphasize the preventive nature of what geriatricians do, right? There's so much that you, in partnership with your physician, internist, family med, geriatrician, can partner together to prevent so much in the way of cognitive impairment and other chronic conditions. So my talk today is called Optimal Aging and Empowered Longevity, because that's what I want for every single one of my patients, whether you're 50 or 96, it doesn't really matter. I want you to age well. And the emphasis of the talk today is what's good for the heart is good for the mind. And you'll see this theme repeated as I go through some of the information and data tonight about how we can keep our mind healthy. I think every one of us in this room knows what heart health is, right? In some way. We know how to keep our heart healthy, and I'm going to show you that those same things, those very things that your doctors talk to you about in keeping your heart healthy will also keep your mind healthy. So we'll just dive right in. And feel free to stop me if something isn't making sense or you can't hear me. I'm very casual, so shout out. So the objectives today, we're going to talk about the scope and urgency of memory loss prevention. So much is being done to discover, to find that cure, to find that miracle medication. And that is so important. My colleagues in neurology work tirelessly every single day to find that answer. But in primary care, as we're waiting for that, we want to do everything we can to keep ourselves healthy and well and push cognitive impairment as far to the future as we can. So we're going to talk about the scope and urgency. We're going to talk about what science reveals about the aging brain. And it's a little bit different than what we previously thought. We're going to talk about genetics, risk, and resilience. So as you all know or may be aware, there are some genes that some people have that increase the risk of developing a certain kind of dementia. But we're going to talk about what some of the latest literature shows in that regard. We have advances in early detection, and this opens up a whole new avenue of prevention. We're going to talk about that, and we're going to talk about the strongest evidence as it relates to lifestyle, and what we can do every single day when we leave this room to know that we're doing everything we can to prevent cognitive impairment. And we'll leave it with some practical evidence-based recommendations. So let's talk about the scope and urgency of memory loss prevention, okay? So as you all know, America is aging, right? Nothing earth-shattering there, except for the first time in US history, older adults are projected to outnumber children in the next 9 years by 2035, right? It's pretty amazing. So this is the first time the US Census Bureau has put this data out. And the population, age 65 and older, is expected to double in the next 30 years. Now, cognitive impairment and brain aging is obviously something that happens to all of us, right? In some capacity, whether it be normal aging or not. And with the population expansion, right, the way the projections show, we're going to, in primary care, in all medical disciplines, be managing a lot more cognitive impairment than I think anyone had anticipated. And because of this, prevention is so important. You'll see here in this slide, this was put out by the Alzheimer's Association, and you can see some dementia statistics here. So the total US population, the estimate is that 1 in 10 people over 65 have Alzheimer's disease. Okay, so that's 10%. And we know that dementia prevalence increases with age, and I'll show you that on the next slide. What's interesting here is you have a map of the United States, and the darker colored purple, right, those are the states with higher prevalence of dementia. So more people living in those states with dementia as compared to the states with the lighter colored purple. And as you would imagine, states like Arizona and Florida, where we have many people who go to retire, right, we see more cognitive impairment in those states. Now, this is a very old study that was published in the Archives of Neurology, and despite how old it is, nothing has really changed. And what it's showing you is that as we age, the numbers of individuals impacted by dementia increases. So when you look at this big bar over here, this tall column, these are individuals over the age of 85. And you can see that if you're over the age of 85, there's almost a 40 to 50% prevalence of cognitive impairment. Yeah?
You saying Alzheimer's and dementia is interchangeable?
We're going to talk about that. Look at that. It's a great question. She asked, are we using Alzheimer's and dementia as interchangeable? That's a great question. We're going to talk about what dementia is and what different forms are. Often when we're speaking about dementia, we'll use the term dementia, but I feel like sometimes people don't know that there are different forms, and everyone relates dementia as Alzheimer's, and that's actually not true. So thank you for bringing that up. But basically, this is showing us that as we get older, the prevalence increases, okay? So again, here's just some numbers. Over 7 million Americans with Alzheimer's. This is expected to double by 2060. This doesn't just impact the United States. This is a global issue, a global issue. And you'll see, I'm gonna show you a roadmap that was put forth by the journal Lancet, and some information from the WHO focused on cognitive impairment. So this is not just local, it is definitely impacting us worldwide, and so we definitely need to focus on it. But if anyone had any doubts about Orange County, this is Orange County data. This is not data showing you prevalence or the numbers of individuals impacted by dementia. What it's showing you here is actually projected population growth or increase. And what do you notice? Which colored line is uptrending? Orange. And orange correlates to those people over 65, right? This is our hometown. This is our county. So as you can see, all of the other age groups, right, all of those other age cohorts are either flat or going down, right? So it's good. It's a good thing, right? It shows that we're aging. It shows that science and medicine has done a good job in managing chronic conditions, treating infection, and making sure people have a long life. What we want is a long and healthy and productive life, right? So again, just more statistics to highlight this growing crisis of cognitive impairment. And I think the reason this is important, and all of these statistics are being flashed on the screen, is that we don't have therapeutics yet, right? We have a few medications, we have a few drugs that can help to slow progression of cognitive impairment down. What we need to do is get ahead of it. We need to do everything we can before someone needs those drugs, before someone needs those medications. And that's why I think these statistics are important. So here's my question to you. Can we prevent dementia? I see some people saying maybe, I see some no. I got a lot of no's. Let's commit. Okay, let's commit. And if you know me at all, you know that I'm like I can't commit to what I'm having for dinner tonight. So I got a real commitment problem. But let's commit, okay? If you think dementia can be prevented, raise your hand. Oh, wonderful. I love it. We're hopeful. This is great. This is really, really good. All right. So let's talk. Let's talk through that. Okay? So can we prevent dementia? So this is a statement put out by the World Health Organization. It says, crucially, while age is the strongest known risk factor for cognitive decline, dementia is not a natural or inevitable consequence of aging. Okay? This does not have to happen. Okay? Even if you have risk factors, it doesn't have to happen. I see patients every single day, day in and day out, in every single clinic, who both their parents, all of the grandparents on both sides had dementia and cognitive impairment, and they are fit as a fiddle. They've gone through cognitive testing, they test completely normal. So much of dementia and cognitive impairment risk is lifestyle focused, right? So it's really important to know this is not inevitable. It's not, this isn't just going to happen to all of us. There's a lot we can do. So we're going to talk about modifiable risk factors, right? Dementia is not inevitable, and if we can focus on our environment and our behavior, it goes a long way. We're going to talk about early intervention for cognitive impairment, and these are things that my neurology colleagues do. But in order for us to find people who need these interventions, we have to employ early intervention strategies. And so we'll talk about that. We're going to talk in detail about modifiable risk factors. And I want you to pay attention to this statement up here. Up to 40% of dementia cases are linked to modifiable risks, like diet, exercise, and smoking, right? So much. I think we really downplay the importance of what we do and what we put into our body. And so I'll show you some data about that. And we know this is true because there are some countries where the dementia rates are actually declining. So that's something to be very hopeful for. And there are certain populations that I'll show you where the rates or incidence of dementia is actually a lot lower than the general public. Okay? And this is important because our brains are resilient, they adapt, and more information and more science is showing us about neuroplasticity and how our brains can, I'm not going to say regenerate, but they can adapt, and that's important. All right, so what is dementia? The lovely lady here in the front asked whether Alzheimer's disease and dementia were interchangeable, and in fact, they're not. Dementia is an umbrella term, but I think it's important for us to understand what is dementia and how we get there. So all of us are experiencing normal aging, right? So if I think about myself, right, I like to think that I'm 25, right, but I am not. But I think about myself at 25, right? I was in medical school. I could spit out those facts. I could learn those textbooks and pages of information. Can I do that now? I could do it, but it would take me a lot longer, right? The speed of which we acquire and consolidate knowledge slows down a little bit. Can we learn? Absolutely. So people who are aging normally experience change, right? In my practice, we're right around tax season. And in my practice, I have people come in all the time, right around this part of the year, and they say, gosh, I'm getting my taxes ready. And I used to be able to do them in a weekend. And now, the papers they're on my desk, and I'm on week 2 or week 1. And it's not that they can't get their taxes done, or they're having problems with calculations, or they're going to be late in filing, or any of that. They will get it all done. It just takes a little bit longer. Now, people who experience a pathologic, right, a not normal change in cognition, they can develop something called mild cognitive impairment. And that is not a normal part of aging. And that is in a situation in which memory or some other domain of cognition is impaired, but they are still able to function normally. They're functionally intact. When that progresses to a deficit in cognitive domain like memory, and they can't function independently anymore, they need help remembering to take their medications, remembering to pay bills, keeping their what we call instrumental and basic activities of daily living going, then they fall into the dementia category. Now, normal aging, just like I mentioned, right? We take some information, we try to learn something, we store it in our mind. We have to pay attention to that information. If we're distracted, if we're thinking about something else, that we're not going to consolidate that memory, right? We have to really be paying attention. We can retrieve that information, and we can even encode it and store it in long-term memory as we age. All part of normal aging. It just takes us a little bit longer to retrieve that information. So when you walk into a room and you're like, what was I doing here? Or you're like, where did I put my keys? Where's my wallet, right? Where's my phone? If you can find those things and move on and carry on with your day, that's completely normal. Like, we see that all the time. I do experience it every single day. Because you're able to retrieve that information just a little bit slower than you could maybe 10 or 20 years ago. So this is a great graph that shows normal aging versus dementia, right? And really what you're seeing here are these green lines are showing you cognition over time. And people who are aging kind of normally, they have very little noticeable change in cognition or thinking or memory, right? There's a little bit, but not much. People who develop an MCI and then eventually a dementia, you can see that dark blue and then the red line kind of going down to the ground, they're really experiencing a profound change that is irreversible, right? They have a noticeable, severe change in cognition, memory, and thinking. Now, this graph is really important because it shows you that for people who are experiencing or will eventually experience a dementia, there is a preclinical phase, right? That preclinical phase. And this preclinical phase, they don't know what's happening, right? They're not experiencing any symptoms. And this is really this is what we want to find. This is where we want to get these folks. We want to get them into aggressive risk factor modification, maybe some brain training, like puzzles, classes, socialization, so we can prevent and delay this phase, the next phases of MCI and dementia as much as we can. So that's really, really what we're looking for, is this preclinical phase. So we talked about what is dementia. It's a syndrome. There are many types. It sometimes has a precursor, which is that MCI or mild cognitive impairment. And there are many different types of dementia. So Alzheimer's disease, which is commonly interchanged with dementia, is one form. There are other forms. There's Lewy body, there's FTD or frontotemporal dementia, vascular dementia. You can see there's a number. So you really, if you're concerned about memory or you're concerned about a loved one's memory, it's important to find a clinician who really understands what these different types are and how to manage each type individually. This is a slide that shows cognitive domains. So we interchange memory and dementia a lot, right? But there are dementias that don't impact memory. People have intact memories, they can remember everything, but they still have a dementing illness. And that's important. And that's because there are 6 cognitive domains. 1 includes learning and memory, but as you can see, there are 5 others that have to do with visual spatial skills and planning and attention. And depending on where the deficits are, that sort of helps us to know what the type of dementia is. These are the 4 most common types of dementia: Alzheimer's, FTD, Lewy body, and vascular. So most common is Alzheimer's disease. We probably have the most information about Alzheimer's. The second most common is vascular. And vascular and Alzheimer's can exist in isolation, but many times they exist together. And so this is why we emphasize making sure that our vascular or heart risk factors are aggressively managed. So let's talk about what are these risk factors that I keep talking about. And I don't think that any one of these will surprise you. We have non-modifiable risk factors, right? I wish I could reverse aging, but I'm stuck. I'm stuck going forward in time, and I can't change my genetics, right? So I have to live within those confines, but I can protect myself in other ways. And so the modifiable risk factors are written here. Traumatic brain injury, right? Especially at any point in life. But if you've experienced traumatic brain injury, that does increase the risk of developing a cognitive disorder. The type of diet that we have, our physical activity. If we have chronic conditions like diabetes, hypertension, and high cholesterol, certain medications increase the risk of cognitive impairment. There's one that's commonly, you'll find it on every single drugstore shelf, and that's Benadryl. So, lots of people take Benadryl for sleep, for allergies. It's a medication that gives geriatricians nightmares because over time it can lead to cognitive impairment. Alcohol. So alcohol was once thought to be protective for the heart and protective for blood pressure maybe and help you to sleep and all of that. But studies show that maybe we shouldn't be consuming alcohol. And if we are, in moderation. Smoking, and then of course social isolation. So this is a diagram. I apologize, it's a little bit hard to see. That I pulled this from the Lancet, and this was a commission on dementia prevention from 2024. They had a commission in 2020 that put out recommendations, and then they updated it in 2024. And this commission feels that you can prevent or delay up to 45% of dementia cases by lifestyle alone. And you can actually see that they put a risk, right? They put a percentage of reduction in cases of dementia if this risk factor is addressed, basically. And you can see that if we address hearing loss, that's a 7% reduction. If we address cholesterol, so high HDL, or depression, or traumatic brain injury, physical inactivity, you can see that this is a cumulative effect that adds up to 45%. Okay, so this is pretty profound. I think we don't really appreciate how much lifestyle matters. So there was a study that looked from the CDC that examined how common these risk factors were in adults over the age of 45, right? And they looked at these risk factors that are here on the screen. And what they found was that in our population, about 50% had high blood pressure, and they did not meet the 30-minute daily exercise recommendation, right? And adults with cognitive decline were more likely to have at least 4 risk factors that may or may not be addressed. Okay, so really, really important to think about blood pressure and to talk to your doctors about blood pressure and diet. I don't think it's talked about enough. I think a lot of physicians sort of say, oh, okay, well, your blood pressure is 140, you're on the borderline, we'll address it next time, and then that next time doesn't come. And so there's this basically sort of months and years go on where these vascular risk factors are not addressed. Okay. So what do we know about the brain? So with Alzheimer's dementia, we are very concerned about the hippocampus, right? That's an area of the brain that's responsible for memory. But we know that so much of cognitive impairment is related to vascular changes. These are the same changes that happen in your heart. And those changes show up in the brain in different ways, okay? And we worry about cumulative brain tissue loss. So you can see kind of in the cartoon, right? You have a healthy brain, it looks nice, it's pink, it's plump, right? You can see a full hippocampus labeled there. And on the right-hand side, you can see that the brain has kind of shrunk, right? The hippocampus is atrophied, and the brain itself has shrunk. And so we are trying to address cumulative brain tissue loss, right, through a comprehensive and holistic plan to prevent cognitive impairment. And we want to think about integrated prevention strategies. Okay. So let's talk about genetics. So people come to me and they say, well, I have, both mom and dad had early dementia, or, I'm concerned about my risk factor because I'm positive for the ApoE4 allele. And yes, it does increase Alzheimer's disease risk because these individuals have additional amyloid burden. But genetic risk is not determined, right? It's not deterministic. It increases your probability. And so even for individuals who are gene positive, we want to, and we see improvement in lifestyle, through lifestyle and environmental factors. So I have a patient, he developed cognitive impairment very young, 45 years of age, strong family history. All siblings have Alzheimer's dementia. Both sets of grandparents had Alzheimer's dementia. And he said, this is not going to happen to me. At the age of 40, went vegan, aggressively managed salt. So basically said, I'm not going to consume salt, went vegan to combat sort of cholesterol and get the inflammation that occurs when we have a less than plant-forward diet, addressed all of that, got involved in sports, started socializing, cut out all of his alcohol, and he is now 65 and has not developed dementia. So it is possible. It's not for everybody, but it is possible, but it does take some work. Okay. So how do we find individuals who we need to aggressively manage risk, right? So we now have some blood biomarkers that are available that can aid in early detection. One of the blood biomarkers that we've used at UCI is called p-tau 217, and it's a blood test. You can go in and you can have a blood test. It kind of indirectly will tell your neurologist or your geriatrician your risk. These blood tests are brand new. They're not perfect. They need a lot of work. We don't really know who should have a blood test at this point. We don't know who shouldn't have a blood test. It's kind of the wild, wild west right now in blood biomarkers. But it's worth a conversation with your primary care or your neurologist or your geriatrician about if your PCP says to you, well, I'll just order that for you, don't worry. Stop them. You really want to have a conversation about what the ramifications are regarding the results. So things like what your insurance company, life insurance policy, what all of those people who are underwriting these very important details of our life, what they would do with this information, we don't know, okay? So we still need some years to figure out how to use these and how to use them appropriately. But I think it's going to be a game changer, right? If we can identify someone objectively at risk, aggressively manage lifestyle modification, maybe get them on some newer therapeutics that can delay cognitive impairment or Alzheimer's dementia, something like a lecanemab, right? Then we're really starting to move the needle in making management of cognitive impairment much more tangible. And again, I just want to highlight that the preclinical phase here is so important. So I'm standing up here in front of you, and I assume, right, that I'm in the preclinical phase, right? Because I want to manage my risk factors, right? My colleagues are all managing their risk factors. And I don't have knock on wood, nobody in my family has dementia, right? But anything is possible. And so you want to really think about yourself in this preclinical / you're normally aging, you're preclinical, you want to do everything you can so you don't fall off that cliff. So let's talk about some practical and evidence-based things we can do, okay? So this is a graphic that shows how interconnected everything that we do is, okay? So let me give you an example. So in geriatric, when you see a geriatrician, we manage your blood pressure and your diabetes and your exercise and your diet and everything, but we do it in the context of something called the geriatric 5 M's, okay? And that means that we address mobility, we address your mind, we address what matters most to you, we address your medications, and we look at multi-complexity. So, for example, if I have a patient that is not sleeping well at night because they're worried about their grandchild who's going to high school, okay, and they're taking Benadryl, right, that medication is going to impact their mind in a negative way. And because they're not sleeping well, they're not going to be able to manage their blood pressure or their weight or their blood sugar because they can't get healthy sleep, right? This is all interconnected. If I eat poorly, I hope none of you saw what I had for dinner tonight, but if you eat poorly, you're going to increase the inflammation in your body, right? And if you increase the inflammation in your body, your genome and your cells are all going to become dysregulated to some degree, right? Theoretically, which is going to cause you to age in an accelerated fashion. Everything we do is interconnected. So it's really important to know that. Okay. So I've kind of said all of these things already, right? What can we do? We need to manage our cardiovascular health. We need to think about exercise and diet. We need to screen and treat sensory issues. Okay, this is really important. So there was a 7% reduction in cognitive impairment based on that Lancet Commission if we could address hearing impairment, right? That's pretty profound. And we know, science has shown us, studies have shown us that hearing loss and cognitive loss are connected. So it's really important that if you or someone that you love is experiencing hearing loss, that you get that treated, okay? Having said that, I've never, ever met a patient that's like, please sign me up for hearing aids, right? I mean, we know they're faulty. They're not great. The technology just isn't there, but really important to address it nonetheless. Mental health, super important. For individuals who suffer from depression, there's an increased risk of cognitive loss, okay? And it's important. We have great treatments for mood-related issues. So we don't want to, I would encourage anyone and everyone to talk to their healthcare provider if you're feeling anxious or down. And there's a lot to be nervous and anxious about in our world, right? And that's okay. We want to address it, and we can address it sometimes with medications and sometimes without, but it's important to address it so that you don't put yourself at unintended risk. And then it's of course important to have a relationship with your doctor, right? Your doctor should want to be talking to you about all of these things, so that anything that's in your mind and in your heart you can discuss and have adequately addressed. So this clinician-individual integration is so important. So let's dive into the cardiovascular risk in a little bit of detail. So this is a picture of a vessel, okay? It's a blood vessel, right? It's the kind of vessel that we have in our heart, for example. And what you're seeing in this yellow kind of bubbly portion is that cholesterol and plaque are building up, right? And if it builds up to a certain point and then becomes unstable, and this is in your heart, you'll have a heart attack. Okay, that's basically what a heart attack is. Now, if this happens in your leg, the vessels of your leg, you can experience something called peripheral arterial disease. And people have pain with walking, and they can have wounds and difficulty with circulation in the lower extremity. Now, if this happens in a large blood vessel of the brain, you can have a stroke, right? So the pathology is very similar, no matter, we're just moving body parts, right? The pathology is very similar. And so what you do to protect your heart by eating a heart-healthy diet, taking your cholesterol medication, making sure your blood pressure is under control, plus or minus a baby aspirin, that's all gonna protect your mind as well. And so I just wanna highlight that what's good for your heart is good for your mind, and it really, really matters. I have a lot of patients that come to me and they're reluctant to take a statin, okay? So like a Lipitor, atorvastatin, or simvastatin. Many patients are afraid of those drugs. They're concerned about side effects. I think a number of years ago, there was something that came out in the literature that they were associated with cognitive decline in some fashion, and that couldn't be farther from what the literature is showing us. They're really important and life-saving medications. So I just want to show that this same sort of pathology that happens in the vessels can happen in the mind. And in fact, I stopped early. So if this happens in a large blood vessel of the brain, you can have a stroke. And we know that strokes are catastrophic, right? Because you can lose the ability to speak, or move part of your face or a limb. But if this happens in the teeny tiny blood vessels of the brain, which this does happen, we can start to see cognitive changes. And you can't really pick this up in an overt way, right? It's just happening to us if we're not managing our risk factors. Because there's nothing really, we're not having a stroke, it's not giving us stroke-like symptoms. So again, really important to manage these vascular risk factors. How do we do that? So physical activity is really important. How many of you all exercise? Oh, I love it. I love this. So keep it up. Definitely want to exercise. I think the recommendation right now is for aerobic activity as well as strength training activity. There have been some small studies I've looked at that show that if you can do this over time, it actually improves cognition in a minor way. I mean, these studies need to be, they need to be duplicated again. They need to have larger cohorts of individuals, but it's very promising, right? Let's see, we talked about alcohol use and alcohol use disorder. So again, we used to think alcohol or a little bit of alcohol was okay, or cardioprotective. We've really moved away from that now. So I had somebody today in my office say, well, I'm drinking wine. I think wine's really important. It's got, some great, there's great nutrients in wine. And I'm like, okay, well, maybe we can get the nutrients some other way. We probably, there's something else going on there. No one needs to have 4 glasses of wine a night, right? I get that a glass of wine every once in a while is okay, but for brain health, we definitely don't advocate for alcohol. There's been some literature looking at cognitive training, right? Cognitive retraining, and there was something that came out in the lay press probably 2 weeks, 4 weeks, a couple months ago, study that looked at cognitive training and how that could actually help people to, think faster if you did it in a certain way. So we completely believe in cognitive training and cognitive intervention, and you guys are all doing that right now, right? You're sitting here today, you're listening to my voice, you're learning something new. Some of you are taking notes, so you're really engaged in the material. and you're sort of learning something new, and the more you learn, the more your brain is being healthy and learning and enhancing itself. So if you're not learning to speak a new language, right? I tell people, even if you're not going to Italy, learn how to speak Italian, right? Learn how to crochet, learn how to code. Like if your grandkids are coding, learn to code with them, right, on the computer. Whatever you don't know, make it a point to learn that. And that will help to strengthen your cognitive abilities. And then social activity, so important. So patients come to me and say, well, I'm doing my Sudoku. I did the New York Times crossword puzzle. And I'm like, great, that's wonderful. Like, keep doing it. But nothing compares to social interaction, right? So think about yourselves as you came here tonight, right? Maybe you have friends in the audience. Maybe you knew a few people, right? So you came and you saw each other. But maybe someone bumped into you that you didn't know who they were, right? And you had to sort of figure out, like, well, what am I going to do? Like, what am I going to say to this person? Like, are they going to like me? Right? It's kind of like high school. You have all these thoughts in your mind about how am I going to be perceived, right? And what am I going to say to this person? Like, if someone says hi to me, like, what am I going to do? Like, do I say hi? Do I say hello? Do I keep the conversation going? And these are all things that are keeping your mind. You don't think about this on a daily basis, right? I mean, if you're like me and my husband, we have the same conversation every day, right? How was work? Great. What's new? Nothing. What do you want for dinner? I don't know, right? Like, you get into these, like, even with my kid, I have a 9-year-old. Like, what happened at school today? Nothing. When's your next test? I don't know, right? We get into these little rote conversations, and we're not really using our mind. Our brain's not being taxed. It's not being exercised. And so when you meet new people and you're learning new things and you're having to juggle this conversation with someone you don't know or know anything about, that's brain exercise right there. Weight management goes along with the vascular risk factors, helps to decrease body inflammation. So obviously it's important as well. And then just a summary of the World Health Organization recommendations. So if you have high blood pressure or you're approaching high blood pressure, you really want to manage it. 140 is not considered normal anymore. Okay? Studies have looked at blood pressure control in older adults, people over the age of 65 and 75, and studies are showing us that it's really important, the older we are, it's important to manage blood pressure regardless of age. It makes a difference. So don't let your PCP tell you 140 is okay. Like, they have to have a good reason for that. They should really be telling you why that is. If you have diabetes or prediabetes or a family history of diabetes or prediabetes, definitely want to address that. Great medications to do it. They're very safe. Lifestyle is very effective. And if you're inclined to try and reverse diabetes, we have a wonderful integrative medicine program at UCI at the Samueli Center, and they will help to get you on a lifestyle program that may be able to even reverse the condition. High cholesterol goes without saying. We talked about depression, and then hearing aids. I can't emphasize enough. If you can't hear or you can't see, high risk of cognitive impairment. Nutritional interventions. We're going to talk about this in a little bit, but nutrition is so important, and I think sometimes we don't emphasize it enough. The Mediterranean diet and the MIND diet have been looked at extensively. There's good quality of evidence to suggest that this type of diet makes a difference, even in the short term. So we definitely advocate for that. And we're not finding that many supplements or vitamins do much. Okay? So people spend a lot of money on vitamins and supplements, and there's a lot of people getting rich, opening these companies that put supplements out there, but in terms of like actual studies and validation, we're not seeing much unless you have a noted nutritional deficiency that we are trying to replete. So, okay. So really what we want to do is we want to be on a diet that is going to protect our brain, that is going to decrease neuroinflammation, decrease our insulin resistance, and prevent us from getting diabetes and prediabetes, increase our antioxidants and our gut microbiome, right? So that we can be healthy individuals. And lots of diets have been looked at, and the two that I think are, or the three that I'll talk about, one is Mediterranean, two is DASH, and three is MIND, okay? So I always have to remind my husband that the Mediterranean diet is not what we get at the local Mediterranean restaurant, okay? Right, where there's lots of like kebabs and beef and, you know, I don't know. There's lots of good and lovely tasting food, but probably not the Mediterranean diet that we're talking about, right? So Mediterranean diet, all of these diets, right, the Mediterranean, DASH, and MIND, they are emphasizing long-chain omega-3 fatty acids, natural sources of C and E, whole grains, fibers, and other micronutrients, and they're minimizing the things that are found in our diet in abundance, and sort of our Western diet, which is fructose, sugars, and trans fats, and processed foods. This is really important because we're also seeing in the United States higher incidence of colon cancer. Okay, so our diet typically is not rich in fiber. And in order to help manage the risk of colon cancer, we have to increase the fiber consumption. Oh yeah, sure.
If you look at the green weight there, see at the top of the slope there, fructose, glucose, processed foods, trans fats, I'm a little unclear as to why that's that.
Oh, what it's showing you is that in the Mediterranean DASH, he's asking about the green triangle. The green triangle, like why are fructose, glucose, and processed foods higher? It's showing you that actually what we want to do, we want to weigh down, it's just counterintuitive. We want to be really heavy on all of these things here in this column and not so much over here. Okay. And again, it's very much like I said, we want to be eating a diet that's going to decrease our body inflammation, neuroinflammation, and help us to combat things like insulin sensitivity and cardiovascular risk. So the DASH diet, this has been around for a very long time. You may be familiar with it. It was designed initially to control hypertension and reduce cholesterol level, right? And it's basically a low-salt diet. So it says no more than 2.3 grams per day. How many tablespoons or teaspoons is 2.3 grams? Anyone want to take a guess? I got one teaspoon. Okay, so real teaspoon, not a lot. These are the kinds of things, these are the quantities that the DASH diet is suggesting. So it is it's heavy on the grains, heavy on the vegetables and fruits. Doesn't really talk about, the types of fats or anything. It's really focused on salt reduction. Then there's the Mediterranean diet. It is the most extensively studied dietary approach. Several systematic reviews of observational studies have concluded that for individuals who stick to a Mediterranean diet, that there is an associated decreased risk of MCI and non-genetic Alzheimer's disease. But you gotta really commit. You gotta go all in. Oops. So what is the Mediterranean diet? It's mainly plant-based, okay? The majority of the meals include vegetables, fruit, whole grains, beans, and seeds. It includes some nuts. Butter and fats are consumed rarely, right? Refined sugar and flour are rare. And small amounts of animal protein, but much less than what we typically consume, okay? So it really does involve flipping. Like you have to kind of go into the pantry and take out a lot of stuff and think about how you're going to incorporate beans and legumes and all of this and seeds into the diet. So there are great books out there. There's great ways to do it. And slowly but surely you can get there. It's just that our society makes it hard, right? Due to expense, due to access. But the benefits of the Mediterranean diet, it prevents muscle mass loss, prevents bone loss, prevents cardiovascular disease, preserves sexual capacity and prevents cognitive decline, and it helps your immune system. So there's so many benefits to this type of diet. And, these are just a couple, Mediterranean diet on healthy older adults. This is just a study kind of corroborating what I'm already saying. Let's talk about the MIND diet. It's very similar to the Mediterranean diet. This was introduced in 2015, and it was introduced by Rush University Medical Center and Harvard School of Public Health, and it was designed to target the aging brain. They studied it, they followed 1,000 people, they did questionnaires over 9 years. These individuals went through cognitive testing, and they noted a lower rate of cognitive decline as compared to those individuals who were on a Mediterranean or a DASH diet alone. The MIND diet is very similar, like I said, to MIND. So it's really emphasizing whole grain, 3 servings of whole grains a day, lots of green leafy vegetables. There's an emphasis on berries in this diet, so blueberries in particular, lean poultry, lean fish. If you have to use a fat, olive oil, lots of nuts. What it's not about the pastries and sweets. It's not about the red meat. Looking at the cheese recommendation there hurt me a little bit. Less than 1 serving a week. Oh my goodness. And then very little butter or margarine. Okay, so MIND diet all the way, Mediterranean diet, definitely think about that. Lots of patients ask me about turmeric, okay, and curcumin, and if there's any benefit there. Long story short, we're not sure. Need more studies. It can be very difficult on the gut. It can be people get a lot of GI distress. My feeling is if you'd like to take it, get it naturally, go to the market and get turmeric root and put it into a smoothie or something of that nature. What's the problem with supplements? There's very little FDA oversight. There's a lot of contamination. Studies have looked at the purity of the contents of supplements. And I kid you not, sometimes the ingredient that you're buying, that you're purchasing the supplement for, it's not even in the pill. So you have to be very careful. If you're interested in supplements in any way, I would look at supplements produced in Germany. Germany does a really good job. It's part of their medical practice. The practitioner, like people like myself, know about supplements, and they have a high quality supplement manufacturing sort of plan. But in the United States, it's pretty much, it's unregulated. Can supplements be harmful? Absolutely. There are studies that show vitamin E, A, beta carotene can increase mortality. So we've seen that in studies. Vitamins can be toxic, so people take high dose vitamin D because they're concerned about bone health. They can become toxic on vitamin D. Vitamins A, D, E, and K, you can become toxic on. Your body stores those. It doesn't pee them out. And for people who are prone to kidney stones, excess vitamin C can be problematic as well. So these are just a couple of points, but if you're taking a lot of supplements or you're interested in supplements, come talk to me. I have a pharmacist in my office that does consultation, and she'll make sure that what you're taking is safe. We talked about optimizing physical health, which is regular exercise, 30 minutes a day, 150 minutes per week with strength training included. I talked about optimizing mental health, right? 1 in 4 individuals has behavioral or mental health related issues. 66% of people are not receiving care for this, and recurrent depression is a risk factor for dementia. So please, please, please prioritize that. We talked about facilitating social engagement in this talk and how important that is. And social relationships are the single most important predictor of happiness and longevity. So really important to stay socially connected. We have gone through COVID, we've gone through social isolation, we're on the other side of that, so definitely, prioritize that. Now, all the things we've talked about are common in certain parts of the world. So what am I highlighting here in this map? Blue zones, right? So blue zones do all of the things that I've talked about, right? They minimize sedentary behavior, like they exercise, they walk a lot. They eat a diet that is centered on whole, non-processed foods. They're plant-forward. They limit alcohol. They prioritize a sense of meaning and purpose in their life. And they have very low rates of chronic disease and cognitive impairment and all of that. So really important to think about making your world a blue zone. We have a blue zone really very close to us, right, in Loma Linda. So think about how you can make your own world, your own sphere, a blue zone, so that it can help you. Yes. They're a blue zone. Yeah. What factors? Yeah, I think it has to do with the community in that area. They are primarily vegetarian. It's a close-knit community. They prioritize spirituality. Yeah. Education, yes. So think about making your world into a blue zone, how you can prioritize that. And then a couple of more slides I'll go through, and then we'll open it up to questions. I wanted to share with you some things that have been in the press lately. I wanted to address that. So, brain training. So there was a study, the active study, that looked at cognitive speed training in individuals, and people participated in this kind of computer program that had to do with speed, and it showed that it decreased the incidence of dementia for up to 20 years when they followed these people. I thought that was interesting. More studies need to be done to corroborate, but it was interesting and it was in the press. And then finally, vaccines, right? So a lot of us have we're sort of burned out on vaccines because of COVID and whatnot, but studies have looked at shingles, the flu shot, RSV vaccine, and Tdap, and there's been a reduction in the risk of the development of cognitive impairment in individuals who are vaccinated. Shingles actually had a 20% reduction over time. People who received the shingles vaccine. So it's pretty amazing. We don't know why. We need to study this more, but the mechanism is thought to have to do with inflammation and boosting the immune system. So your immune system is important, right? It doesn't just help you to not get a cold or a cough or the flu, but it also helps to protect your body and your organs and everything else. So more to come on that. But I thought those two things that had been in the press were interesting. So with that, I'm going to open it up to questions. Yes.
Two questions. What is the website for that YouTube? If you have the YouTube address we can go to, or just search your name?
For me personally?
No, for this talk tonight.
Oh, that is a great question. I don't know.
Here, go ahead. I'm going to take the microphone.
Oh. So the question was, Benadryl, right, which is diphenhydramine, is it similar to gabapentin? And gabapentin is a medication that we use to treat a few different things, but most commonly neuropathy, and they are not the same.
And so you don't have the same problem with gabapentin?
No.
And then also the YouTube address.
Yeah, and she'll give you that.
Okay, the YouTube address. The YouTube address for her talk tonight, she said that they're filming. Okay, thank you.
So the other question was hydroxyzine. Is that an issue, hydroxyzine? So hydroxyzine has other side effects that we're concerned about. I think we are concerned about hydroxyzine, not as much as diphenhydramine. Yeah. Oh, sorry. I'll come back to you. I can hear you. So the question is, how do you modify risk for a TBI? Unfortunately, if you've sustained a TBI, a traumatic brain injury, you have that risk, right? You've got it. But you should, for whoever has experienced a traumatic brain injury, they should be very aggressive with all the other things that we've talked about. Yeah, but we can't reverse the TBI. Yeah.
More questions here?
We have a question right here.
Conga's coming.
Allegra, you asked about? That's fine. Allegra's fine if you have allergies. Yeah. The question is Allegra okay if you have seasonal allergies? Allegra, the over-the-counter anti-allergy medication, and that's okay. Yeah.
Hi, I've been to a couple of lectures that the Alzheimer's Association put on, and they said that untreated urinary tract infections are also causes of dementia. My mother had an untreated UTI for about 15 years, and she has dementia. So is that coincidental, or is that true?
That's a great question. So I'm not aware of research that shows that untreated UTIs cause dementia, but what we see in patients who have an underlying cognitive impairment is that UTI, right, more than just causing, discomfort and burning and bladder irritation, can actually cause delirium in patients, which then causes them to have an acute worsening of their cognitive ability. So they become very confused, they can start seeing things that aren't there, and they can start behaving, in ways that are not sort of natural or part of their baseline functioning. And when we treat the UTI, they get better. Yeah.
I have two questions.
Yeah.
First one, do you have a list of all the medications besides Benadryl that might affect it somewhere?
Oh, that's a great question. Gosh, probably too many for me to list.
Maybe a
Benadryl's
website?
Yeah, you could actually, if you're interested, there's something called the Beers criteria or the Beers list.
Like
having a beer, BEERS. I know, it's a list of medications that are, and this is a list that's been put together by, prominent pharmacists and medical individuals. And it talks about the risks to taking these medications if if you have certain conditions or if you're an older adult. We use a lot of medications on that list. Okay, you'll find there's a lot of medications, like insulin is on that list. But it just kind of, you have to take a minute and say, okay, do I really need this? Why am I taking this medication? I mean, I'm saying Benadryl is bad, right? Benadryl is bad if you're using it every night to go to sleep, because there are better, different, safer medications for you. But, for people that receive a blood transfusion, right, they have to get Benadryl. It's part of the pre-medication. It's part of the pre-meds to lower your body's allergic response to something. So there are certain situations where you have to use these products. We just want you to be very thoughtful about it. But an exhaustive list is the Beers. It's Beers.
Thank you. And the second question kind of goes back to the other person's question about the urinary tract infections. So I just read today about, I think it's called geriatric urinary syndrome, and that there are things you can do to prevent that from happening or to help keep it in check, because UTIs are so common in older adults and do not have the same symptoms as when we're younger. Like there's no burning sensation, there's no idea, and it causes people to have falls. So what are the things that can be done to help prevent UTIs later in life?
Yeah, I think they're the same things that we would do, we would recommend for younger individuals. So hydration is really important. Hydration cannot be emphasized enough. So, everyone says, well, you need to have 6 to 8 glasses of water a day or fluids a day. Look at your own health issues. If you have a history of cardiac disease or congestive heart failure, that might be too much for you. But definitely 6 to 8 glasses of fluids a day, very important. You don't want to be holding on to your urine. So in healthcare, we're notorious for this, right? Because we have busy clinics, we're in the hospital, we're running around, and nobody pees, right? We pass about 10 bathrooms on the way to what we're doing, and nobody ever stops. And no one thinks that no one feels like they have time to pee. If you gotta go, go. It's like what I told my daughter's 9. When she was 2, you gotta go, you go. So don't hold it, because whatever you're holding in your bladder, there's a chance that it can get infected. What else? Post-coital urination, so after having sex, use the bathroom, pee. For most patients who do not have cognitive impairment and they have the ability to tell us their symptoms, the symptoms are the same. You can have burning and frequency and irritation, and you can even have a little bit of pink tinged urine. You want to get to your doctor or the urgent care. Don't get mad at your doctor if they ask you for a sample. So when you're young, the doctors will treat you with 3 days of Cipro or 3 days of an antibiotic. The more we do that, the more resistance we develop. And so in geriatrics, we really want a culture. We want to collect that urine, we want to send it to the lab, we want to see what bug is growing, because a lot of times, probably just from my own practice, 30% of these individuals who have symptoms don't have a UTI. They're not growing out any bacteria. And so to give them an antibiotic disrupts their gut microbiome, puts them at risk to C. diff and diarrhea and all these other things, right? So, expect that your doctor's going to ask for a culture. The other reason for that is as we age, our kidney function goes down. And when our kidney function goes down to a certain point, the antibiotics like Cipro, we have to be very careful about, because you can actually have tendon rupture and all kinds of other badness related to certain antibiotics if we don't dose adjust for your kidney function. So we're looking at all of those things.
More questions? Over. Oh.
Is there anything to the commercials for Prevagen? Is it snake oil?
Yeah, there's another one too. There's Prevagen, and there's what is that? There's like some there's ginkgo biloba. There's another one. Yeah, I can't even think of it. I can't. No, it's something. And the reason I know that there's something else is because, the geriatrician's dad, I went over to my parents' house. Hey, Sonia, I bought this for myself. And I'm like, just talk to me. Save your money and talk to me. So lots of people take them. They're over the counter. If you're taking them, talk to your doctor about the use. I don't think studies that have been individually validated or really show any benefit. I don't recommend them. It's not a treatment recommendation that I have for my patients.
Oh, way over here. Okay. Just 2 more questions. Yeah.
The link between alcoholism and dementia. It's a great question. So alcohol is a neurotoxin, right? It's a neurotoxin. If you drink enough of it, you're going to get neuropathy, which is it's nerve damage, right? So it's a bone marrow toxin, it's a neurotoxin, and it is not great for your vascular risk factor modification. And so we don't recommend it for that reason. We do see alcohol-related cognitive impairment in individuals who maybe moderately drank for many, many years.
Is it called wet brain?
Is it called wet brain?
Yes.
I'm not familiar with that.
Okay.
But there are different syndromes associated with alcohol ingestion. Yeah, so you want to be very careful about that, particularly if you're at higher risk.
Did you see the news item today? I just saw it, that they're detecting a link between changes in speech pattern and the tendency to dementia.
Yes.
You saw that?
Yes.
What was it?
Changes in speech pattern.
Changes in speech pattern as it relates to cognitive impairment. So I haven't seen the actual article that you're referencing, but we do know that individuals who have Alzheimer's dementia have word finding difficulty, right? It's one of the things that if we test somebody with Alzheimer's on those batteries of testing that look at language and word naming and things like that, they are depressed. And you can see it in conversation with someone who has Alzheimer's, right? in my office, I see it all the time. So I'll say to somebody, I had a patient, today, gosh, it's been really hot. And they look at you and they're like, yeah. Well, what season is it? And they'll say, yeah. They kind of follow you. Like, yeah, it's been kind of hot. Yeah, sure, it's been hot. But, it's summer, so it's hot. And then you have to stop and say, well, it's not really summer yet, right? But they think that it's summer, so they're a little confused. And then you say, well, what month is it? And they can't tell you the month. They're word finding. They can't find that word. They can't find the word for the month that it is. They can't necessarily find the word for the season that it is. Maybe you ask them about their medication. They can't give you the name or the word for medication. They start having naming issues. And if you listen very carefully to someone with Alzheimer's, you'll pick that pattern up.
So thank you, Dr. Sehgal. If you go to the foundation website and you click on programs under Medicine in Our Backyard, all of our lectures are listed there, and you can access them online and stream them. It takes a couple of weeks before we get them up, and then of course this is also on YouTube under the foundation and also under the name of the speaker. So, and our next meeting is in April, I think 27th, and we will be doing knees. Whether you need surgery or how to handle your knee pain. So thank you all for coming. Go forward and have a great evening.
Thank you, guys.